Welcome back to the Deep Dive. We're absolutely thrilled to have you join us for this latest deep dive into the world of pancreatic cancer.
Great to be here.
We're rounding out our comprehensive GI oncology series today, focusing on putting all the pieces together, the guidelines, the planning specifics, and navigating those tricky case-based scenarios.
That's right. Over our previous sessions, we've really journeyed through the incredibly complex and, let's be honest, often challenging landscape of pancreatic cancer. We've wrestled with the adjuvant debate, embraced the neoadjuvant revolution, and had what I think was a pretty good masterclass on SBRT, stereotactic body radiation therapy, which has really changed the game in many ways.
Absolutely.
Now it's time for the ultimate synthesis. We're going to translate all that high-level data from landmark trials into practical, actionable plans you can use in your daily practice.
Our mission today is really to solidify your understanding of pancreatic cancer management, making you feel hopefully a bit more confident when facing these complex cases. We'll kick things off by distilling the key recommendations from the major guidelines, giving you that essential roadmap.
Yeah.
Then we're going to virtually sit down at the treatment planning station for a detailed workshop covering both postoperative conventional radiation therapy and those modern SBRT techniques.
And then finally, we'll dive into some classic clinical dilemmas, the kind that might keep you up at night sometimes, that really sharpen your decision-making skills.
Definitely.
Pancreatic cancer management can absolutely feel overwhelming, but our goal today is to help you cut through the noise, distilling it down into clear, logical frameworks that empower you to make informed choices. So let's jump in.
Okay. To truly tackle the inherent complexity of pancreatic cancer management, the guidelines from ASCO, the American Society of Clinical Oncology, and ASTRO, the American Society for Radiation Oncology, they provide such a crucial logical framework.
They really do.
When we boil it down, you'll primarily navigate two main pathways in your practice.
Yeah, the first pathway, and let's start here because it represents, well, a significant paradigm shift, is for potentially curable disease.
Right.
This umbrella term includes both resectable and borderline resectable tumors. And the central, undeniable theme here, the North Star guiding our modern approach, is neoadjuvant therapy first.
Neoadjuvant first. Why such a strong preference?
Well, it stems from the historical shadow of upfront surgery, where we just saw unacceptably high rates of positive margins.
Or one resections, yeah.
Exactly. And for an oncology professional like yourself, you know that a positive margin isn't just a technical detail. It's a profound predictor of local recurrence and, sadly, poorer overall survival. By giving therapy up front, we aim to shrink the tumor, sterilize microscopic disease, and critically improve the likelihood of getting that clean R0 resection.
Makes sense.
So for medically fit patients, and this is our starting point, the standard recommendation is to initiate with systemic chemotherapy.
Get that systemic control early.
Precisely. We're talking about aggressively treating micrometastatic disease that might be lurking even if we can't see it on imaging.
Okay.
When it comes to the preferred regimen for these fit patients, FOLFIRINOX really stands out.
That's the big one.
It is. And this isn't just an arbitrary choice. It's deeply rooted in its proven efficacy, particularly illuminated by a landmark study like the Protégé 24 trial.
Can you remind us about that one?
Sure. Protégé 24 was a phase 3 adjuvant trial comparing FOLFIRINOX to gemcitabine after resection. And the results were, well, astounding.
Right.
Median overall survival was 54.4 months for FOLFIRINOX versus 35 months for gemcitabine. Hazard ratio of 0.64.
Wow, that's a big difference.
That's a huge survival advantage. Now, while Protégé 24 was adjuvant, its profound impact on systemic control has translated directly into its preferred use in the neoadjuvant setting, where we aim for maximal tumor shrinkage and systemic eradication up front.
Okay, so use the effective adjuvant regimen neoadjuvantly.
Exactly. But of course, this aggressive regimen comes with its own set of toxicities, right? And not every patient can tolerate it.
Sure.
So for those who are less fit, we absolutely have excellent alternatives, like gemcitabine-based doublets, which still provide substantial systemic control and can be better tolerated. The key is individualizing treatment, always.
Right, tailoring it to the patient. So we've put patients through that intensive induction chemotherapy, which, let's be honest, is no walk in the park.
Not at all.
But after that, the role of radiation is where things get really fascinating and, quite frankly, remains a significant point of contention and active debate in our field.
Absolutely. It's a hot topic.
On one side, we have compelling pro-radiation evidence. The PreOPanC-1 trial, for example, provides level 1 evidence that a gemcitabine-based chemoradiation regimen improves survival in the neoadjuvant setting for borderline resectable pancreatic cancer.
Level 1 evidence for survival is huge.
It is. That's a powerful statement. Radiation, in this context, directly impacts how long a patient lives. Just to recap PreOPanC-1, it randomized borderline resectable patients to upfront surgery versus neoadjuvant chemoradiation, gemcitabine with 50.4 gray, then surgery.
And the neoadjuvant arm.
Significantly higher R0 resection rate, 63% versus 31%, and crucially numerically better median overall survival, about 22 versus 17 months.
So that supports neoadjuvant chemoradiation.
It does. However, and here's where the nuance comes in, we also saw excellent results from the chemotherapy-only arm of the Alliance, a 021501 trial.
Right, the Alliance trial.
This trial looked at neoadjuvant mFOLFIRINOX for borderline resectable pancreatic cancer. While it wasn't designed to directly compare radiation versus no radiation, the impressive R0 resection rates, a stunning 60% after mFOLFIRINOX alone, and overall survival data, median OS around 30 months.
Wow.
In the chemotherapy-only arm after surgery led many to question if radiation was always necessary for these patients.
So chemo alone did really well there.
Exactly. This creates a legitimate clinical conundrum. So to be clear, this remains a key area of ongoing clinical investigation and passionate discussion within the radiation oncology and surgical oncology communities.
Yeah, you see differing practices.
There isn't a universally accepted one-size-fits-all answer. Patient-specific factors like depth of vascular involvement, the patient's performance status, even institutional expertise very much influence the ultimate decision of whether to add consolidative radiation after neoadjuvant chemotherapy.
It's about careful, multidisciplinary deliberation. Tumor board is key.
Absolutely.
Okay. Now, let's pivot our focus to the second major pathway. Locally advanced unresectable pancreatic cancer, or LAPC.
LAPC.
For LAPC, the goal shifts quite significantly. Since surgical resection isn't initially an option due to extensive vascular involvement, our primary aim moves from upfront cure to achieving long-term disease control and, ideally, improving quality of life.
Right, different goals.
And just like with the potentially curable pathway, the very first step for LAPC is intensive induction chemotherapy.
Same first step, chemo.
Right, typically delivered for about 4 to 6 months. The rationale here is twofold. First, to aggressively treat any micrometastatic disease that might already be present but isn't yet clinically detectable. And second, it serves as a crucial biological selection process.
Ah, see who responds.
Exactly. If a patient progresses rapidly on induction chemotherapy, it suggests an aggressive tumor biology unlikely to benefit much from local treatment. However, for those patients who show stable disease, or even better tumor regression after this induction chemotherapy, the critical question then becomes, what's the optimal consolidative therapy? How do we best control the primary tumor site?
And this brings us directly to a true game changer in the LAPC landscape, the pivotal LAP-07 trial.
LAP-07, yes.
Yeah.
A really important one.
This trial compared conventional TAMR radiation to continued chemotherapy for patients with LAPC who had achieved stable disease after 4 months of induction chemo. What it showed was fascinating and, frankly, led to a major shift in practice.
Okay, what were the findings?
It demonstrated unequivocally that consolidative conventional chemoradiation does improve local control.
So better control at the primary site.
Yes. The median progression-free survival at the local level was significantly longer in the chemoradiation arm, about 11 months versus maybe 7 months for the chemo-only arm. But here's the kicker, and this is the vital takeaway. It offered no overall survival benefit over continued chemotherapy alone.
No OS benefit. Wow.
The median overall survival was essentially the same in both arms, roughly 15 months. This was a profound finding because while we could control the tumor locally with conventional radiation, it simply didn't translate into patients living longer.
So controlling the local disease didn't change the ultimate outcome.
In that trial setting, with conventional chemoradiation, exactly. So because of these very clear results from LAP-07, practice has largely shifted away from using conventional dose radiation for LAPC as a routine consolidative strategy for all patients.
Makes sense. So what do we do now?
Instead, for those patients who are stable after induction chemotherapy and where robust local control is still a significant concern, maybe due to pain, impending obstruction, or just a desire for maximal local disease burden reduction consolidative SBRT is increasingly becoming the preferred approach.
SBRT comes in.
This is a crucial distinction. SBRT allows us to deliver a much higher, more ablative dose to the tumor in a significantly shorter time frame, typically over just, 5 days or so.
Much more potent and quicker.
Right. The beauty of this approach is that it maximizes local control potency, often with less toxicity than conventional long-course chemoradiation, and perhaps most importantly, it doesn't significantly delay the resumption or continuation of systemic therapy.
Which LAP07 showed is critical.
Exactly. Systemic therapy is so often vital for managing that microscopic disease elsewhere in the body. SBRT allows us to be precise and efficient locally without sacrificing systemic treatment time.
Okay, that makes a lot of sense. All right, now that we've navigated the overarching guideline pathways, let's get our hands dirty, so to speak, and move to our virtual treatment planning station.
Love it. The practical stuff.
This is where the rubber meets the road, translating all that evidence into actionable plans. We're going to cover 2 key scenarios that you will undoubtedly encounter in your clinical practice. First, postoperative conventional radiation therapy planning, and then a deep dive into neoadjuvant SBRT planning.
Okay, first up, let's consider a very common scenario. Postoperative conventional radiation therapy planning. Imagine you have a patient who, unfortunately, underwent an upfront Whipple procedure for a pancreatic head tumor.
Yep.
But the final pathology report comes back with that dreaded finding, a positive retroperitoneal margin. Or perhaps they have node-positive disease, or other high-risk features like T3, T4 disease, or poor differentiation.
Common consult, sadly.
It is. This is a classic indication for adjuvant chemoradiation. For this type of case, the standard dose we typically aim for is 45 gray delivered in 25 fractions.
45 and 25, standard fractionation.
Right. This dose aims to encompass the entire tumor bed and any at-risk regional nodes. Following that initial course, we would then typically boost the specific positive margin area or areas of high-risk residual disease to a higher total dose, ranging from 50.4 to 54 gray.
So a boost to the margin up to 50.4 or 54 gray.
Exactly. This ensures we deliver an adequate ablative intent to that high-risk microscopic disease, hoping to sterilize any cells left behind. The specific boost dose often depends on, how close the positive margin is to critical organs like the duodenum.
Okay. Now, let's talk target delineation for postoperative conventional RT. This is a super high-yield topic, not just for practice, but definitely for board examinations.
Absolutely. Pay attention here.
So pay very close attention, as meticulous contouring is paramount for both efficacy and safety. First, for the tumor bed itself, you should always fuse the preoperative CT or MRI scans with your planning CT.
Fusion is key.
It's essential. This helps ensure you're accurately targeting the original extent of the disease, even after surgical changes. Carefully contour the preoperative gross tumor volume, or GTV.
The original tumor footprint.
Right. Don't forget to meticulously delineate any surgical clips that were placed during the procedure, as these are invaluable guides to the surgical bed and often mark the margins.
Find those clips.
Critically, you also need to contour the pancreatic jejunostomy anastomosis. This is the surgical connection between the remaining pancreas and the small bowel, and it's an area at significant risk for recurrence due to potential microscopic disease spread along the surgical planes.
Don't miss the anastomosis.
Definitely not. This entire combination of the original tumor volume, surgical clips, and the anastomosis forms your core target, your sort of tumor bed CTV.
Okay, tumor bed covered. What about vessels?
Next, and this is absolutely critical for comprehensive coverage and a common point of error for those new to this, are the key vessels. You must cover the perineural and perivascular pathways.
The sneaky spreaders.
Exactly. Pancreatic cancer has this infamous propensity for spreading along nerves and around blood vessels, making these microscopic extensions very difficult to detect with conventional imaging. Missing these pathways can lead to frustrating local recurrences.
Right.
So this means meticulously contouring the main arteries and veins and giving them an appropriate margin to account for potential microscopic disease extension. Specifically, and this is something you should commit to memory, you need to contour the proximal 1 to 1.5 centimeters of the celiac artery.
Celiac, okay. 1 to 1.5 centimeters.
Which is a common pathway for superior nodal spread. Then you'll contour the proximal 2.5 to 3 centimeters of the superior mesenteric artery, or SMA.
SMA, 2.5 to 3 centimeters. That's often involved.
It is. This vessel is crucial because it's often closely involved with the pancreatic head, and perineural spread along its course is a hallmark of the disease. And finally, you'll contour the portal vein, specifically from its confluence with the SMV and splenic vein up to the hepatic hilum.
Portal vein from confluence to hilum.
Right. The portal vein is a common route for local recurrence, especially along its perivascular lymphatic drainage. To help you remember these essential vessels, the celiac artery, the SMA, and the portal vein, you can use the mnemonic CSP.
CSP celiac, SMA, portal vein. I like it.
Think celiac, SMA, portal vein. This ensures you hit all the critical areas for potential microscopic spread. It's like tracing the potential routes of escape for those sneaky cancer cells.
CSP. Got it. So building on that meticulous vessel delineation, once you have those core structures and key peripancreatic vessels accurately contoured, you'll then move to create your nodal clinical target volume, or CTV.
Right, the nodal CTV.
You will primarily create this by expanding around those critical vascular structures we just discussed, the CSP vessel.
Okay, expand around CSP. How much?
A standard expansion that's commonly used is about 1 to 1.5 centimeters around the celiac, SMA, and portal vein. This captures the immediate lymphatic drainage around these high-risk areas.
1 to 1.5 centimeter expansion.
But we're not done there for comprehensive nodal coverage, especially for pancreatic head tumors. To cover the para-aortic nodes, which are also at significant risk,
Aortics too, okay.
you'll also create an expansion of the aorta itself. Typically, this means expanding about 2.5 centimeters to the right of the aorta because that's where the main para-aortic lymphatic chains lie, and about 1 centimeter to the left.
2.5 centimeters right, 1 centimeter left of the aorta.
Correct. The final CTV for your treatment plan is a meticulous union of all these components. The tumor bed structures that you meticulously contoured, including clips and anastomosis, and this comprehensive nodal volume derived from your vascular and aortic expansions.
Union of tumor bed and nodal expansion.
Precisely. Finally, to account for daily setup uncertainties, organ motion, and subtle patient variations, a 0.5 to 1 centimeter margin is then added to that CTV to create your planning target volume, or PTV.
Standard PTV margin, 0.5 to 1 centimeter.
Right. That's the volume you'll actually prescribe your full dose to. It's a precise art form, really, blending anatomy, pathology, and imaging.
Okay, comprehensive. Next, let's shift gears quite dramatically to SBRT planning for LAPC.
All right, SBRT.
This is a scenario we're seeing more and more of in practice, especially after the insights from LAP07. Let's imagine we're planning a consolidative SBRT case for an LAPC patient after they've successfully completed their induction chemo, shown stable disease, maybe even some tumor regression, making them an excellent candidate for local consolidation. In this context, the goal of SBRT is to deliver an incredibly potent ablative dose to the remaining tumor, essentially trying to sterilize any remaining microscopic or macroscopic disease locally and potentially downstage them for possible resection later.
Ablative dose. What regimen?
A common and very well-supported regimen, backed by a growing body of institutional evidence in Phase 2 trials, is 50 Gray delivered in 5 fractions.
50 and 5.
Right. This specific regimen is chosen because it achieves a biologically effective dose, or BED, calculated with an alpha-beta ratio of 10 for tumor control of 100 Gray.
BED of 100, that's high.
It's a very high ablative dose in a remarkably short period, making it very effective for local control.
Okay, 50 and 5. Now, when it comes to SBRT planning for the pancreas, critical organ at-risk constraints are not just important, they are absolutely key.
Understatement of the year.
Right. In fact, it's probably the single most paramount aspect of safe and effective SBRT delivery in this anatomical region. It's all about meticulously sparing the duodenum and the stomach.
Duodenum and stomach, got it.
These are the primary organs at risk for severe late toxicities, specifically ulceration, perforation, and bleeding, which, as we can all appreciate, can be truly devastating for the patient and incredibly challenging, if not impossible to manage once they occur.
Nightmare complications.
Exactly. So, for the duodenum, the key constraints, based on robust data from several institutional series and consensus papers like the Corsair series, are paramount. The volume of the duodenum receiving 33 Gray should be less than 1 cc.
V33, less than 1 cc. That's the magic number.
That is the critical hard constraint, a red line you absolutely do not want to cross. It's non-negotiable. Furthermore, the maximum point dose to the duodenum should ideally be kept under 40 Gray, if at all possible.
Max dose under 40 J.
To help you truly visualize this, think of the duodenum not just as an organ, but as an incredibly delicate, thin-walled, exquisite glass sculpture.
Okay, delicate glass.
The pancreatic tumor, on the other hand, is like a hard, stubborn nut you're trying to crack with a high-powered laser. You have to precisely target that nut with a powerful dose of radiation without shattering the glass.
Nice analogy. Don't break the glass.
Don't break the glass. Why is the duodenum so sensitive? Its unique radiobiology, particularly its rapidly proliferating mucosal lining, makes it exceptionally vulnerable to high-dose radiation. A fraction of a cubic centimeter can mean the difference between a successful treatment and a life-threatening ulcer or even a fatal bleed.
It's that biological vulnerability.
Exactly. It's not just memorizing the constraint. A simple, practical rule of thumb to help ensure safety is to ensure you maintain a physical separation, a margin of at least 5 to 7 millimeters between your PCV and the luminal GI tract.
5 to 7 millimeter gap, that's your safety zone.
That physical separation is your best friend in pancreatic SBRT. It's also critical to note that if the tumor directly invades the duodenum, SBRT is generally considered relatively contraindicated.
Makes sense. Can't get the separation.
In such cases, achieving these crucial dose limits becomes extremely challenging, if not impossible, without an unacceptable risk of severe complications. We simply can't risk shattering that glass. Finally, while not as often dose-limiting as the GI tract in this scenario, it's crucial to watch the spinal cord.
Cord dose.
For the spinal cord, a common maximum dose for a 5-fraction regimen consistent with safety standards is 30 Gray.
Cord max 30 jam for 5 fractions.
And always remember to check the kidneys, liver, and small bowel constraints too, though the duodenum will likely be your primary challenge.
Duodenum first, then check the others. Okay. All right, let's shift gears and put some of this critical knowledge to the test with our board blitz section.
All right, board blitz.
I'll present a classic high-yield board-style case, just like you might encounter on an examination. Take a moment to think through your answer, visualizing the patient and the planning, and then we'll break it down together, discussing the nuances of each option.
I love these. This is where we really see if the information has stuck. Lay it on me, I'm ready.
Excellent. Let's dive into case 1. A 60-year-old man presents with newly diagnosed borderline resectable pancreatic cancer. After multidisciplinary discussion, he completes neoadjuvant M-Elfarinox with excellent response, showing significant tumor shrinkage. The decision is made to proceed with consolidative SBRT to the primary tumor before reassessment for surgery. When planning his SBRT, which of the following is the most critical dose volume constraint to respect, given the potential for severe toxicity? A. Mean liver dose less than 20 Gray. B. Contralateral kidney V12 less than 33%. C. Duodenum V33 less than 1 ccD. Spinal cord maximum dose less than 35 Gray.
Okay, thinking. Borderline resectable, post-chemo, SBRT planning. Critical constraint. Gotta be the duodenum.
The best answer here, without a doubt, is C. Duodenum V33 less than 1 cc.
And why C?
Well, while all of these are indeed important constraints that you would meticulously consider in a comprehensive plan because we aim for holistic safety, the duodenum is unequivocally the most critical and often the most challenging dose-limiting structure in pancreatic SBRT.
Exceeding that volumetric constraint of V33, less than 1 cc, significantly, and I mean significantly, increases the risk of late grade 3 or higher toxicity.
Like ulcers and bleeding.
Exactly. Devastating complications like severe ulceration, bleeding, or even perforation, which can be life-threatening and incredibly difficult to manage. The liver, kidneys, and spinal cord are certainly important, but in the context of pancreatic SBRT, the duodenum is the paramount safety concern, making this constraint a red flag you simply cannot ignore. It's where the unique radiobiology of the GI tract intersects with our ablative intent.
Absolutely spot on. That duodenal constraint is our constant companion and sometimes our biggest headache in pancreatic SBRT planning. Okay, let's move to case 2. You are meticulous in your contouring, planning a postoperative clinical target volume, or CTV, for a patient who had a Whipple procedure for a pancreatic head adenocarcinoma. The surgical pathology report notes an inadequate lymph node dissection, heightening your concern for residual microscopic nodal disease. According to the RTOG 08-48 consensus guidelines, which of the following vascular structures are essential to include as part of the elective nodal volume, requiring careful expansion for comprehensive coverage? A. The renal arteries and veins. B. The superior mesenteric artery, celiac artery, and portal vein. C. The entire thoracic aorta. D. The iliac vessels.
Okay, postoperative contouring. Inadequate nodes. RTOG 0848. Key vessels for nodal coverage. That's the CSP mnemonic again. The correct answer here is B. The superior mesenteric artery, celiac artery, and portal vein.
And the rationale.
The RTOG 0848 Atlas, which, as we discussed, is really a foundational document for comprehensive nodal coverage in this area, specifically states that the higher-risk nodal regions for pancreatic cancer closely follow the main peripancreatic vasculature.
Right, follow the vessels.
Therefore, comprehensive coverage of the celiac axis, the SMA, and the portal vein by expanding around them is absolutely essential. This ensures you adequately treat potential microscopic perineural and perivascular disease, which, as we covered, is a hallmark of pancreatic cancer spread and a common route for local recurrence.
Hmm.
While renal vessels are important for dose sparing, they're not the target here. Thoracic aorta and iliacs are just too far afield for primary regional nodal drainage. So yeah, remember that CSP mnemonic, it really guides your contouring here.
Excellent recall. That mnemonic is golden. Now for our final board blitz question, case 3. A 67-year-old man with locally advanced unresectable pancreatic cancer, or LAPC, is found to have stable disease after 4 months of FOLFIRINOX. He's feeling well, tolerating therapy, and naturally he asks about the next steps in his treatment, wanting to understand his options. You discuss the results of the LAP-07 trial with him. Which statement best summarizes the findings of adding consolidative conventional chemoradiation versus simply continuing chemotherapy in patients with LAPC who are stable after induction chemotherapy? A. It significantly improves both local control and overall survival. B. It significantly improves overall survival but not local control. C. It has no benefit and should not be offered. D. It improves local control but does not improve overall survival.
Okay. LAPC, stable after chemo. LAP-07 findings. Conventional chemoradiation versus chemo. This is the key takeaway from that trial. The best answer for this case is D. It improves local control but does not improve overall survival.
Explain that a bit more.
The addition of conventional dose radiation did provide a clear local control benefit in patients with LAPC who were stable after induction chemo, meaning the primary tumor site was better managed.
So local control was better.
Yes. However, and this is the critical distinction that shifted our practice, this local control benefit did not translate into an overall survival advantage in the trial. Patients did not live longer with the addition of that specific type of radiation.
Got it.
Options A and B are incorrect because overall survival wasn't improved. C is too extreme as it did provide local control benefit, which can be important for symptom management sometimes. This finding is precisely why our practice patterns have evolved, often favoring more potent, shorter course SBRT for local consolidation or focusing entirely on continued systemic therapy in this scenario.
Right.
It taught us that local control, while vital, isn't always sufficient on its own to extend life when systemic disease is the primary driver of mortality.
Perfectly summarized. Those board blitz questions really highlight the critical decision points and anatomical considerations in pancreatic radiation. Now, let's transition to some high-yield clinical pearls to take away from our discussion today.
Pearls, love these.
These are points that will serve you incredibly well in practice, helping you navigate complex scenarios and certainly for your board preparation.
Okay, my first pearl for you, and I cannot emphasize this enough, is to truly master the NCCN criteria for resectability.
Foundational.
Absolutely. Knowing these criteria inside and out, understanding the nuances of arterial and venous involvement that define resectable, borderline resectable, and locally advanced disease is absolutely foundational. It's your North Star for accurate staging and, consequently, for guiding the entire appropriate treatment planning pathway in pancreatic cancer.
Can't plan without staging correctly.
Exactly. Understanding if a tumor is resectable, borderline, or locally advanced dictates the entire treatment paradigm, so get intimately comfortable with those definitions and their imaging correlates. Without this, you're flying blind.
Great point. Building on that, my second pearl, particularly regarding postoperative conventional radiation planning. Always use the ARTIS-OGO 848 Atlas to guide your coverage.
Use the Atlas.
Yes, not just for the tumor bed, but crucially for those key peripancreatic vessels we discussed, the celiac, SMA, and portal vein, CSP.
All right, CSP again.
This isn't just about memorizing a diagram. It ensures you're targeting all the high-risk areas accurately and comprehensively, addressing the common patterns of recurrence and microscopic disease spread in pancreatic cancer. It's an invaluable tool that distills years of anatomical and pathological understanding into a practical guide. Don't try to reinvent the wheel here. Leverage this atlas.
Excellent pearl. Okay, for SBRT to the pancreas, my third pearl is that the duodenum is your primary concern, full stop.
The glass sculpture.
Exactly. Always aim to keep that V33 less than 1 cc, and ideally your max point dose below 40 gray. This isn't just a number. This strict constraint is vital for minimizing the risk of severe, potentially life-threatening late GI toxicity.
Can't stress it enough.
As we highlighted with our delicate glass analogy, if those dose limits are violated, the consequences can be devastating, leading to ulcers, bleeds, or even fistulas. It's truly the Achilles heel of pancreatic SBRT, and your meticulous attention to this constraint will define the safety of your treatments.
Very well put. And my final pearl for today, which truly encapsulates the complexity of modern pancreatic cancer care, is to be prepared to articulate the nuanced evidence-based arguments for and against consolidative radiation after induction chemotherapy for LAPC.
Understanding the why.
Precisely. Understanding the LAP07 trial and its profound implications, specifically the local control benefit without an overall survival advantage for conventional radiation, is critical. You need to be able to guide patient discussions, setting realistic expectations about local control versus overall survival benefits, and confidently explain why we might choose SBRT or continued systemic therapy instead.
Informed discussions.
Right. This isn't about rigid dogma. It's about informed, patient-centered decision-making in a rapidly evolving landscape.
What a deep dive we've had today. We've really covered a lot of ground, synthesizing complex evidence and translating it into practical application for pancreatic cancer, hopefully making sense of what can feel like a truly overwhelming disease.
Yeah, hopefully demystified some of it. To recap, we walked through the critical guideline pathways for both potentially curable and locally advanced pancreatic cancer, emphasizing the evolving and now widely accepted role of neoadjuvant therapy as the preferred upfront approach, as well as the important considerations for consolidative therapies post-chemotherapy. We then dove deep into the specifics of planning both conventional postoperative radiation, including crucial nodal and vascular coverage, using atlases like RTOG 0848.
And we extensively reviewed SBRT planning for LAPC, highlighting the absolute necessity of respecting critical organ at-risk constraints, especially for the duodenum, which, as we've learned, is the primary dose-limiting structure.
Definitely.
Our board blitz cases further cemented these key concepts, ensuring you can apply this knowledge under pressure and recall those vital details when it counts.
We have now completed our comprehensive 4-part deep dive series on pancreatic cancer. We truly hope this has been incredibly valuable in solidifying your understanding of this challenging disease and equipping you with the knowledge and confidence to manage these complex cases effectively.
Next time, we continue our GI series by traveling to the liver, which presents its own unique set of challenges.
The liver. Exciting.
We will begin our series on hepatocellular carcinoma, starting with Part 1, the HCC Toolkit, where we'll cover staging, interventional radiology techniques, and systemic therapy, setting the stage for future discussions.
Sounds great. You can access show notes and comprehensive practice oral boards at radoncsmartlearn.com. That's radonsmartlearn.com.
Perfect.
And please make sure to subscribe to the deep dive for our next deep dive. Thanks so much for tuning in.
And as you reflect on today's discussion, consider this. If our local control techniques for pancreatic cancer continue to improve dramatically, as SBRT suggests they might, how might the next generation of systemic therapies targeting microscopic disease finally bridge that elusive gap between superb local control and a true significant leap in overall survival for our patients with locally advanced disease? What breakthroughs do you think will get us there? Something to ponder until next time.